Hi, everyone. My name is Sahil Jumkawala, and I'm a third-year internal medicine resident at the Rutgers, New Jersey Medical School program and a proud CardioNerds Academy fellow. Thank you so much for tuning in today.
Hello, everyone, and thank you so much for tuning in today. My name is Nazlı Okumuş. I'm a second-year general cardiology fellow at Allegheny Health Network in Pittsburgh, and I serve as the CardioNerds ambassador in my program. On this episode, we are featuring the FLAME trial, FlowTriever for acute massive pulmonary embolism. It's our pleasure to be joined by Dr. Mitchell Silver and Dr. Jim Horowitz, who are the co-principal investigators of this exciting study. This interview is part of a CardioNerds SCAI 2022 collaboration with mentorship from Dr. Alex Brazil. Dr. Silver is an interventional cardiologist and vascular medicine specialist at Ohio Health and Vascular Physicians in Columbus, Ohio, specializing in managing the full spectrum of arterial, venous, and lymphatic diseases. He serves as the director of the Center for Critical Limb Care at Riverside Methodist Hospital and has authored over 200 peer-reviewed manuscripts and book chapters with research interests in the areas of venous thrombosis, pulmonary embolism, carotid stenting, and endovascular limb salvage. Dr. Horowitz is a clinical assistant professor in the Department of Medicine and NYU Grossman School of Medicine, where he also serves as assistant chief of service for the Division of Cardiology and assistant program director of the Pulmonary Disease and Critical Care Medicine Fellowship. Dr. Horowitz is actively engaged in research with interests including pulmonary embolism response teams, thromboembolic disease associated with COVID-19, and percutaneous management of DVTs and PEs. Thank you both for taking the time to speak with us. I will start with the first question. Over the past couple of years, there has been increasing interest in the management of PE with widespread use of percutaneous interventions, such as mechanical thrombectomy and catheter-directed thrombolysis in high, intermediate, and high-risk PE. Dr. Silver, can you tell us what led to a trial investigating FlowTriever in patients with high-risk PE, and what might it add over CDT and systemic thrombolytics in this patient group?
Thank you for the question, and I think it's a good one, so I can kind of give the background behind the spirit of the FLAME trial. So I think all of us are quite humbled by the mortality that we see with high-risk PE, and we really haven't impacted it in over 20 years. If you recall, the ICOPER study in 1999 found a 52% 90-day mortality in high-risk PE patients, which was quite high. And now when we fast forward to more contemporary series, it's about a 40% rate of mortality at 90 days. So that's really quite humbling. Then, if you take into account the standard of care, which is systemic thrombolysis, if you consider the 2% intracranial hemorrhage rate and the 10 to 14% rate of major bleeding, it's a big problem because that's the standard of care. So Jim and I and other KOLs felt it was really incumbent on all of us to look at alternatives, such as large bore catheter aspiration. So essentially, a lytic-free strategy, such as a large bore catheter aspiration system, that can really, rapidly reverse the hemodynamic compromise seen in these high-risk PE patients, quickly improve gas exchange abnormalities, we think really may offer an evolution to the next step. Study together. That's why a technology like FlowTriever really adds something. It's a rapid reperfusion strategy without the risk of systemic lysis.
Thank you very much. These are great points.
Thank you for sharing that, Dr. Silver. Dr. Horowitz, would you be able to tell us some more about the design of the FLAME trial?
Yeah, to kind of partner with what Mitch just said, I think there were two things that happened that were very interesting. One was in the early, the first cohort of the FLASH data, the first 250 and change patients, there was about 10% of patients who were massive PE patients or high-risk patients. And basically, they all lived after FlowTriever. And, as Mitch just said, that's not supposed to happen. The mortality is, 30 to 50 to whatever percent, depending on what study you look at. So that really piqued our interest when that first cohort was presented in, like, I guess 2020, 2021. And that led to discussion with Mitch. And then I talked about, and Mitch will never tell you this because he's too humble. But the cool thing is that at his system at Ohio Health, you can roll into the ED with a massive PE and be worked up and treated like a STEMI and be in the lab in 20 minutes, you know, door to balloon time kind of thing, with door to suction thrombectomy time, and have this kind of clot removed that, you know, has not happened historically. So I think the combination of those two kind of ideas led to this thought of how can we follow up this kind of like a bit of an idea from Flash and figure out if there's actually a signal there. Now, we didn't think that we had the power to randomize. So what we have is basically two parallel registries. So basically it's two, and part of that is because, you know, one of the fun things about PE, or funny things about PE, is that there's so many devices in the space that maybe not everybody in your group is savvy with each device. You know, maybe like it's changing year to year, there's new devices, there's new this, maybe 2 or 3 all do blah, blah, blah. So basically our thought was, if we have sites that are very, very savvy, you know, let them do a series of massive PEs, and then another separate series do standard of care, which is TPA or whatever you do, and then we'll see what happens. And lo and behold, you know, my research career in the past was basically centered around submassive PE, which is a just difficult space to work in, because the mortality numbers make it that, you know, powering these studies is very difficult. But with massive PE, it's so dangerous that we realized that we could do probably create some good data with a small number of patients in each arm, like sub 100 patients. And the thought was that, you know, I think, you know, Mitch would agree, I think that the thought from everybody involved was like, let's move the needle on the guidelines. That's what we want to do. So hopefully, you know, when we get data from this trial, we can see, you know, that that there's a massive difference, no pun intended, sorry, dad joke, and then maybe move the needle on moving some guidelines as well.
Thank you, Dr. Horowitz. These are really interesting points. And another question is, one of the exclusion criteria of the study was history of pulmonary hypertension with pulmonary systolic pressure greater than 70. Can you tell us more about the effects of underlying chronic pulmonary hypertension and how the cutoff of 70 was determined?
I mean, you know, I will tell you that it's interesting. When we started our first PERT, and now it's 2012, it was 10 years ago. One of my mentors, Evelyn Horn, who runs the PH program at Cornell, said, listen, we will support you, but just make sure that you don't kind of muck around with the chronic patients, because they can be unpredictable. So, you know, so basically the point is that if somebody's pH on echo or cath is greater than, say, 60 or 70, the idea is that there's some chronicity there. This is not an acute event. Your RV is a thin-walled structure that generally operates at 1/5 of the pressure systemically. And so if your PA pressure is that high, there's something else going on, you know. I know, like, the classic New England Journal trial shows, you know, says that 4% of patients have CTEP, but I wonder if you repeat this right now, you sound very different, because we see a lot of patients who look like they have chronicity either by the PA pressure, the size of the main PA on CT, RV 3-wall thickening, X, Y, and Z. So we wanted to make it as pure as possible, because the hemodynamics, as you guys know, as cardiologists, the person who is failing acutely with RV failure is very different than the person who has acute on chronic, you know, in the sense that like someone may have a PA pressure of 100, and then as they're failing, it trickles down to 90, 80, 70, 50, 40, 30, 20. So we just thought it was a very different disease, and we thought it would kind of cause some possible conflicts with the purity of the data. Mitch, you agree with, is that?
You know, Jim, you're spot on. So we all know that if you acutely load the right ventricle, it's not going to generate a pressure of 70. So that in of itself tells us that there is some chronicity to what's been happening in the pulmonary vasculature. And those patients have a completely different natural history. So we wanted to exclude that. But importantly, on the trial design, it's very real world, which I like very much. You know, the issue with RCTs is there's a lot of inclusion and exclusion criteria, and patients are almost cherry picked, where in FLAME, particularly in the non-FlowTriever arm, doctors are able to do whatever non-FlowTriever therapy they want, you know, catheter-directed lysis, systemic lysis. So it's very real world, and I think it'll be a very rich source of data to, like Jim said, hopefully be the thing to maybe support changing in guidelines. The proof will be in the pudding, but we'll see.
Thank you both for that insight, and we look forward to seeing the results. Dr. Silver, so our next question, utilization of eCPR has been more emphasized in the recent years, along with the question of timing and necessity for ECMO cannulation in patients with high-risk PE. Are you anticipating to find more answers with this study regarding timing and necessity of ECMO in high-risk PE treated with mechanical thrombectomy?
Thanks, Sahil. So there's definitely a role for advanced mechanical support in patients with high-risk PE, you know, in particular ECMO. In fact, I think most high-volume centers that are treating high-risk PE patients are very savvy at it, and they're very keen on recognizing the patient that starts that death spiral when they have obstructive shock with PE. And what we've learned, it's a good thing to intervene early with advanced, you know, support devices like ECMO, because what it affords, then you can do the procedure in a much more supported fashion, obviously. So I think most high volume centers that are doing high risk PE are commonly putting patients on advanced support, again, because once they start that death spiral, it's hard to reverse it. And those are judgment calls at the bedside. You know, we can talk a little bit about what makes us put people on advanced support, but it's an important thing. So yes, I think FLAME should highlight and help us understand the timing of when to institute advanced support. And that's something that I think we'll tease out, you know, from the study. But yes, it's an important modality to be able to do that in the high-risk PE patient.
Thank you, Dr. Silver. FLASH registry showed impressive on-table hemodynamic improvements, as well as encouraging long-term results up to 6 months in high intermediate risk PE treated with mechanical thrombectomy. What are the expected results and outcomes of this trial in high-risk PE?
Let me make one comment and then kick it back to Mitch. You know, I think that, again, you know, not to toot his horn too much, but I mean, Mitch was the person who first turned me on to this. The idea that your ECMO team is your cath team, is your PE team, is paramount, right? Your ECMO in PE is your balloon pump / Impella in PCI. This is part of the disease state. It is not a complication. It is part of the disease. And if you're at a center that can do that, it will just help you grow your team and grow your service.
It's a great analogy, Jim. I completely agree. It's like doing a high-risk PCI without a left ventricular assist device. We know that that improves outcomes, and it just makes sense. Once that patient starts the death spiral, put them on support. You know, cath labs that are savvy at it can do it in the ER. They can do it in the cath suite. We use ultrasound and micropuncture technique. It's a safe thing to do. It really is.
Thank you. And additional question that we had is regarding the tremendous amount of variations in management of high-risk PE, such as systemic thrombolysis, surgical thrombectomy, mechanical thrombectomy, and ECMO cannulation with the anticoagulation approach. The lack of solid evidence-based approach and clinical challenges in the management of intermediate to high-risk PE led to the concept of the PE response team. How do you think that the FLAME trial will affect the choice of treatment, and what should be some of the next steps moving forward? Dr. Horowitz, if you'd like to start.
Yeah, sure. I mean, I think usually in my like PE slide deck, which I use religiously, I have this slide that says, like, when I got into PE work 10 years ago, the needle had not moved since 1960. So, TPA came out, heparin came out, and then my slide is basically heparin and hope for the best, filter and forget, and TPA too late. So, that's where we were for a long, long time. And I'll tell you that, when we have these conversations with PERTs all over the country all the time, everyone says, well, maybe I don't have ECMO, maybe I don't have this. And that's okay, because TPA works well. Because the first problem is one, early diagnosis. We've solved that with CT for the past 30 years. The second problem is early anticoagulation. Scott Cameron's group from Cleveland Clinic showed that, we're terrible at it. And then his initiation of a PERT improved that dramatically. And then there's data from the mid 2000s that shows that TPA use for massive PE actually went down between 99 and 2010, despite obviously knowing that it saves lives, as Jeff Klein's group has showed as well, because people are scared of, as Mitch said, that 2 or 3% of cerebral hemorrhage. So people are not doing the basics, the fundamentals. It's like playing a sport, on some level, it's like the fundamentals. Early anticoagulation, low Vanox instead of heparin, because we know that people don't get their PTT therapeutic. It failed, half the time they're not therapeutic after 12 hours. We know that they're not giving early TPA when people are actually coding and dying in massive. So like that's the lowest rung, and I think PERT has helped with that dramatically by spreading the gospel across the country. We talked about the PERT consortium about this idea of, and at our recent cardiac critical care symposium at NYU about, how do we find enough sites to like staff all of these new randomized controlled trials for P? And the answer is we have PERTs. There's hundreds of PERTs across the country. These are sites that can now, help just by being active, by raising awareness. They can help by randomizing. They can drive the whole PE land forward in a way that we haven't done, in 60 years. And that's dramatic. For the rest of the stuff, we also know that historically, cardiac surgery for PE was thought to be, no man's land. Basically, you went to the OR and you died. And that data from Sam Goldhaber 20 years ago has, there's newer data basically that shows that, that was probably because people weren't getting into the surgeon's hands until they were half dead. Think about the idea of a patient coming into the ED, going to a medicine intern, going to medicine resident, medicine attending, surgical consult, surgical chief, surgeon themselves, CT surgery. That takes days, right? But with the modern PERT scenario, you can get a patient to the OR in a few hours. I mean, maybe not every day. It may be, maybe not every day, every night, depending on your site, but like it can happen. And so I think we've seen as a community that is much less morbid than we thought. And if you talk to CT surgeons, they'll actually tell you that doing an embolectomy is way simpler than even a cabbage. I mean, it's basically one incision and just start pulling stuff out. So I think if you can get them the right patients in the right time frame, then you can make, life or death difference. And I'll leave the rest of the stuff to Mitch.
Those are great comments, Jim. And I would just look at it, in a different way, but very similarly philosophically. I think, and in the area of my research the last few years, is the care pathway for venous disease in general, be it DVT or pulmonary embolus, needs fixed. Venous disease has been an orphan for years. People just don't understand it. And so to Jim's point, the care pathway right now is broken. It's chaotic. The approach is very fragmented. It's inconsistent, depending which ER doctor sees the patient, etc. But to his point, yes, rapid diagnosis, getting the results to the correct doctor in time, who then activates a team, really will improve outcomes. And we're seeing that. We really are. So the whole care pathway continuum needs fixed in venous disease in general. And the PERT Consortium's really done a fantastic job with that. They really have.
And the percutaneous procedures have just exploded in the past, decade.
Thank you so much for sharing how this multidisciplinary approach has helped the field move forward. Drs. Silver and Dr. Horowitz, we can't thank you enough for your time and for your expertise today. We're very excited to see the outcomes of this trial published, as many people are also anxiously waiting for the data to be available. Thank you so much for joining us today, and take care.